Results of Cadence, a phase 2 randomized placebo-controlled study evaluating the activin signaling inhibitor sotatercept. Pulmonary arterial hypertension is a progressive disease caused by pulmonary vascular remodeling. In part, this is due to an imbalance between proliferative and anti-proliferative signaling pathways. Among proliferative signaling pathways, activin plays a significant role. This leads to pulmonary endothelial and smooth muscle cell proliferation with sustained vasoconstriction and inflammation, resulting in rigid luminal narrowing of pulmonary arteries. Sotatercept is a first-in-class activin signaling pathway. It is a fusion protein. It's a fusion of human immunoglobulin, which is bound to the activin type 2A receptor. So it binds and removes activin, which is involved in progressive remodeling, thus rebalancing the vascular homeostasis. Furthermore, it may result in reverse remodeling. In animal models, there is some regression of the disease because the endothelial cells and smooth muscle cells, which obliterate the lumen, could go into apoptosis. Heart failure with preserved ejection fraction HFpEF is associated with substantial morbidity and mortality with limited disease-modifying therapies. Pulmonary hypertension complicates HFpEF and is associated with greater symptom burden and marked functional impairment. Combined post and pre-capillary pulmonary hypertension, or CPC-PH HFpEF, is a distinct condition characterized by pulmonary vascular remodeling and increased pulmonary vascular resistance, leading to a poor prognosis and high mortality. Prior trials of pulmonary artery hypertension therapies have shown no benefit or potential harm. Cadence is the first study to evaluate sotatercept in patients with CPC-PH HFpEF. Patients were randomized to placebo or one of two doses of sotatercept, 0.3 mg per kilogram or 0.7 mg per kilogram, every 3 weeks for a total of 24 weeks. These are the baseline characteristics. More women enrolled than men. Characteristics were evenly distributed amongst the three groups otherwise. Patients were symptomatic, with 2/3 being NYJ class 3 and 1/3 functional class 2. Patients had a high median NT-proBNP of 119 picograms per milliliter and low functional capacity with a median 6-minute walk distance of 273.8 meters. Patients had an elevated mean arterial pressure of 43 millimeters of mercury, an elevated wedge pressure of 21 millimeters of mercury, and an elevated PVR of 5.2 Wood units. These are the three parameters that define CPC-PH HFpEF. Cardiac output was 4.1 liters per minute. Patients were well treated on background HFpEF medications. Cadence met its primary endpoint. A decrease in PVR for both the 0.7 and 0.3 milligram per kilogram dosing groups are shown here. Sotatercept used yielded a statistically significant placebo-corrected decrease in PVR at 24 weeks of 0.75 units in the 0.7 milligram per kilogram dose and 1.02 units in the 0.3 milligram per kilogram dose. On the right, you can see a significant reduction in the right arterial pressure, mean pulmonary arterial pressure, and wedge pressure. There was lower cardiac output, but maintenance of oxygen delivery. The 6-minute walk test increased by 20.3 meters in the 0.3 milligram group and 5.8 meters in the 0.7 group. NT-proBNP improved in both these groups. Patients tended to improve or maintain their functional class on either dose compared with placebo. Sotatercept was well tolerated. Adverse events occurred in all three groups with equal frequency. Only 3 patients discontinued therapy due to adverse events on the 0.7 milligram per kilogram dose. Selected adverse events of special interest, such as increased hemoglobin, occurred on therapy. And despite an older population and larger use of anticoagulants, bleeding events were similar across all three groups, including a low rate of epistaxis. So in summary, sotatercept was evaluated in CPC-PH HFpEF. The trial met its primary endpoint, a reduction of PVR with hemodynamic findings suggestive of direct pulmonary vascular and cardiac benefits, including improvement in wedge pressure. There were improvements in the 6-minute walk distance, NT-proBNP, and NYJ functional class. Cadence establishes proof of concept for the activin signaling inhibitor sotatercept in patients with CPC-PH HFpEF, a condition for which there are currently no approved therapies.